So I'll start. Good evening to all. Today is the fifth topic that we're taking under cardinal manifestations from Harrison's under medicine. And today's topic is pretty much straightforward, yet very important and difficult to understand. Sometimes I only get confused. The topic that we're looking today is on incontinence, specifically urinary incontinence, and how bladder functions. All the symptoms related to the lower urinary tract symptoms, also called as LUTS. So LUTS stands for lower urinary tract symptoms, and these encompass a lot of symptoms ranging from frequency, urgency, hesitancy, precipitancy, and all. We'll be understanding each one of those symptoms very importantly. At the broad end, what we have to understand is that this session is very important for those people who are practicing in hospital and OPD wise, and all these problems range from a child to a young adult female to a middle-aged man to old people to institutionalized to OPD patients. So it encompasses a lot of patients with a wide spectrum. At the same time, like our last session on syncope, the causes of urinary incontinence spread over different subspecialties, even crossing over to surgical specialties. It has involvement with urologists, gynecologists, oncologists, and also with internal medicine and infectious diseases. So what we need to understand about urinary incontinence is that it's a symptom that does not cause a lot of mortality, very minimal mortality, but at the same time it has a lot of morbidity. So someone's life, someone's social activities will be completely restricted if they have urinary incontinence. It's a taboo to go out with having somebody having urinary incontinence, and it's that stigmatous. So to understand, and the patients sometimes don't come out with problems, and even if they do come out, it's usually very severe and end stage. And it's our responsibility to understand all the symptoms and to ask a proper history and to come to a diagnosis and follow up with treatment. What is important also here is that this topic in itself yields itself, so nicely to history taking. So someone who is a very young physician like us should understand that this topic yields itself to history taking, and a lot of diagnosis and a lot of clues can be taken by history alone. So that is all about the introduction to urinary incontinence. I will be talking incontinence in a broader heading, but I will delve deep into a core medicine neurology topic, which is neurogenic bladder. So neurogenic bladder is a type of urge incontinence, but we'll go into it in depth because stress incontinence is usually under the urology and gynecology banner, but at the same time overflow incontinence is again under the neurological banner. But the one thing that is totally a truly medicine topic is neurogenic bladder. So look at these 5 scenarios. You have 5 patients over here, and these 5 patients are all different age groups with different problems. Now, it's very important, like I told you, to take history properly. But if you're having a patient who's speaking to you in English and giving you history in English, just imagine what they could mean by difficulty passing urine, difficulty while passing urine, and passing out while passing urine. The last thing that we have was covered in the last session, which was vasovagal syncope or micturition syncope. So this is not a topic that we have to deal with today. But the first 2 topics is difficulty passing urine and difficulty while passing urine. These 2 are extremely different and needs to be analyzed. But at face value, all patients come out with the only complaint is there's some problem with urination, some difficulty with urination. It could range from frequency, dysuria, hematuria, anything, but they'll not be able to tell it out unless you go and probe with closed-end questions. So we'll come back to these questions at the end of this session to understand and get answers. The 66-year-old man with BPH, benign prostatic hyperplasia, with difficulty passing urine. What could this be due to? 66-year-old man with post-prostatectomy, probably due to the BPH or prostatic cancer, with involuntary micturition. A 34-year-old lady with difficulty passing urine. That's all she'll come out with. An 80-year-old lady with recurrent UTI and involuntary urination. A 50-year-old man who needs to squat and urinate since the last 2 years. So this is a complaint that they come out with. So these whole range of complaints are all having a common algorithm, which we're going to discuss today. And this is a topic that is not usually discussed by a lot of people. That's why I'm taking this topic in the starting sessions of cardinal manifestations. So Today we're going to learn about the micturition reflex. So last time we learned about the syncope reflex. So we learned the afferent parasympathetic, the center, and the efferent sympathetic. Correct? On the similar lines, today we are going to learn not about the baroreflex, but about the micturition reflex. So all about the anatomy and physiology of the micturition reflex is neural regulation, what is lower urinary tract symptoms or LUTS, how to go about taking history in the patient, what is incontinence, that's the major crux of this entire session. Incontinence is basically involuntary leakage of urine. Okay, so we're going to go in deep about one type of incontinence, which is urge incontinence, and neurogenic cause of it. To understand what is the difference between LMN and UMN bladder, what are the different treatment strategies for incontinence in general, and what is a typical topic in Harrison's that is there in cardinal manifestation, which is painful bladder syndrome or interstitial cystitis. So we're going to touch upon all these topics. First, let's understand the micturition reflex. So you have basically, there are mainly two parts in the entire micturition reflex. One is the part that is completely neural, and one part that is with respect to non-neural. So this is what I could classify it as. This is my entire understanding of micturition reflex, which is easier to begin this entire lecture with. So if you go to neural part of the micturition reflex, it involves the cortex, okay? Then you get the pons, which is very important. The pontine micturition center is very important. It is the main seat for entire control. And then you get the sacral, okay? Then from here, you get the bladder. So let us say this is the bladder. Okay, this is the detrusor muscle. Okay, then you have the trigone, okay, and the internal sphincter, and then you have the external sphincter. Okay, so these are the parts. Detrusor, internal sphincter comes with the trigone, because part of the trigone is only the internal sphincter and external sphincter. The function of both the sphincters is to prevent urine leakage. Okay, so if the sphincters contract, they're going to cause closure of the entire lumen. So now what we have to understand is the autonomic innervation. So there are two types of nervous system, so somatic and autonomic. So somatic goes to external sphincter, so which is the somatic nerves, which is basically the pudendal nerve. Okay, so this pudendal nerve is controlled by the sacral center. Okay, I'll draw the sacrum here. The sacral spinal cord, S2 to S4. The spinal cord segments S2 to S4, and typically what nucleus we call it as Onuf's nucleus. This Onuf's nucleus is going to give stimulation for the pudendal nerve to cause voluntary. It's under our control. So external sphincter will get closed if we choose to close it. If it will open if we choose to open it. So it is basically under voluntary control. But it's not the same. The voluntary control, this is entire somatic in nature. This entire part is autonomic. So if I have to draw autonomic, again from the sacral cords, S2 to S4, parasympathetic outflow is there. So this parasympathetic outflow goes to the detrusor, and the receptor is M3, which is muscarinic 3. Okay, and then you have T11 to L2. This is the thoracolumbar outflow. I told you thoracolumbar outflow is basically sympathetic in nature. So this sympathetic outflow basically goes to the detrusor and to the internal sphincter. So internal sphincter receives input only from the sympathetic nerve. So this is via the alpha 1, okay, and this is via the beta 3. Okay, that's very important for you to understand. So M3 is coming from the parasympathetic, and beta 3 and alpha 1 is coming from the sympathetic. So sympathetic and parasympathetic outflow is comprising the autonomic innervation of the bladder. So if you look at this diagram again, so if you come from below, it's easy to understand. You have the external urethral sphincter, which is in the urogenital diaphragm. So there are a lot of muscles in the pelvic floor. So these pelvic floor muscles need to contract, and coaptation should take place. This coaptation, or the symmetric contraction with equal strength on both sides, it's called as coaptation. So this coaptation has to take place in the pelvic floor muscles, the urogenital diaphragm, to close the external urethral sphincter. This is by the pudendal nerve. Okay, now you have the internal sphincter, which is alpha 1, okay, and the beta 3 receptor on the detrusor. These beta 3 receptors and the alpha 1 receptors is part of the sympathetic outflow, which is from T11 to L2. Okay, then we have M3. So M3 is again on the detrusor. Here, this is again coming from the same place where pudendal nerve came from, S2 to S4, but this is parasympathetic. This is not voluntary. So detrusor internal sphincter is not voluntary. That is we have to understand. So what is pelvic nerve? What is hypogastric nerve? What is pudendal nerve? Please don't get confused. Pudendal nerve is somatic under voluntary control, external urethral sphincter, whereas the hypogastric nerve is part of sympathetic involuntary, which is both to the detrusor and to the alpha 1 in the internal sphincter, and pelvic nerve is called pelvic parasympathetic, PP. Pelvic parasympathetic nerves are going to the detrusor via the M3. So a very easy way to remember is parasympathetic is PPP. Everything is literally P. So parasympathetic is pelvic nerves. It promotes peeing and pooping. So excuse my language, but then this is how you will remember it. It saves you a lot of effort and time. So it promotes peeing and pooping. So obviously it is going to cause increased motility in the GI tract to cause diarrhea if in excess, and it's going to cause increased motility even in the genitourinary system. So it is going to promote micturition. So parasympathetic activity promotes micturition, promotes GI motility, and is carried through the pelvic nerves. And this is completely involuntary. So this is how you understand. This is the basic understanding of the autonomic and the somatic supply of the bladder. So this is just the part in the pelvis, correct? I told you there's an entire part below the external urethral sphincter that is important to the micturition itself. That is the coordination of symmetric contraction, which is called as coaptation of the urogenital diaphragm. At the same time, we have to remember that we have this part we have finished. Now we have cortex, pons, and sacrum. Now, if I tell you that the supra-sacral innervation is as important as the infrasacral innervation, that is to say, it is not the cortex which is important for the regulation of micturition reflex, like in syncope, where it was the NTS and RVLM, CVLM. Here it is the pontine micturition center. So if this is pons, there are two parts to pons, medial and lateral, let us say. So the medial pons is M, lateral pons is L. So this M center is called the Barrington's nucleus. M is called the Barrington's nucleus. So Barrington's center is with respect to, it actually promotes micturition. So M and M, it promotes micturition. Whereas lateral part is called the L region. It's actually called the L region, which actually prevents micturition and promotes storage. So the other way to remember, apart from the PPP mnemonic, is the SS mnemonic, which is sympathetic promotes storage of urine. Okay, so this is very important for one to realize. So cortex is the mediofrontal lobe. So mediofrontal lobe is going to influence the appropriateness of where one can actually micturate. So it is with respect to the social cognition, it is a seat to, where a person feels safe, an animal feels safe to micturate, okay? Because while micturating or while actually passing stools, the animal actually is guarded. So that I mean, it's not guarded. So it is liable to being eaten by the predator. So that's why it's very important for the cortex to realize that it is safe. Only then you can micturate or you can defecate. So it is the mediofrontal cortex. Then it comes down to pons, which is the pontine micturition center, which is medial and lateral. And from there downwards, the sacral thoracolumbar outflow, T11 to L2. And then below that is the sacral, which is S2 to S4, where you get both parasympathetic outflow and you get the somatic pudendal nerve. So, but the thing is that this is just for you to understand what comes from the top to bottom. There is no impulse that comes that neatly from cortex till the sacrum. It is not that easy. It's not like the UMN tracts, pyramidal tracts, where everything starts from the cortex and the cortical input is the most important to the bladder. It is definitely not the case. So how is the organization of the impulse? So the impulse, like I told you, does not move from top to bottom. So the impulse moves from the bladder itself to the sacrum. These two control everything. This is the most important loop. So there were the first physiologist who described this entire loop, which is important in micturition, is called Bradley. So this is one of the 5 loops of Bradley, which is between sacrum and the bladder or the detrusor itself. So as detrusor goes on filling up, urine keeps coming from the ureter and it goes on filling up till 150 ml. There is no problem. 150 ml is where the nerve traffic starts going into the sacrum. This is the afferent sensory nerves, which goes to the sacrum. It goes in a very low, constant level. So the input is like this. So it's as small and spaced out nerve traffic. Then once it goes up till 450, what happens is the detrusor is very large now. It is extremely swollen up. So now the nerve impulse is now at a very high frequency, and the amplitude goes on increasing. So once the amplitude goes on increasing, the sacrum can no longer control the storage. Okay, so now it is going to send the impulses up also. So if it goes up, what do you get? You get the sympathetic tract and then the pons. So sacrum now requests the pons and the thoracolumbar outflow to help it in expanding even more. So sympathetic system, which is above the sacrum, comes for help and helps in storage. So above 450, the nerve traffic goes up. Okay, up to the brainstem. So now the nucleus that is actually firing a lot is L, which is promoting storage, which is the L region in pons, which I told you promotes storage and prevents micturition. So this is helping up go up till whatever above 450. At 600, urgency is very much predominantly present. The patient starts understanding that he needs to micturate. So the nerve impulses are extremely high in frequency. So at 600, the nerve impulses are frequent. By 800, there is painful urgency. By this is the physiological capacity of the bladder. And at 1000 or 1 liter, the pain becomes extremely high. No one can stop it. And this is the anatomical capacity of the bladder, which is 1000, which is 1 liter. So 150, 450, 600, 800, and 1000. These are important numbers for you to understand. Now, at around 600 and above, the M region gets activated. Okay, so the M region is activated, sacrum is activated. Now, if sacrum does not receive an impulse from the M region to micturate, it micturates by itself. This I want you to understand. At around 600 and above, if the cortex is not giving the signal, if the cortex is not giving a safe signal, and if the pons M region is not activating the sacrum takes the control onto itself, activates the micturition, and causes a parasympathetic surge to promote micturition by itself. Otherwise, it's going to be detrimental and it might rupture the bladder. So sacrum acts as a safe spot here. So after 600, sacrum waits for some time for the M region to activate. If it doesn't, it takes upon itself and then continues to micturate. If it receives an impulse from the M region, then it will take that impulse, it will cause a parasympathetic outflow impulse and causes micturition. So this is the supra sacral control of the bladder. This is what is important. Cortex has nothing to do other than to tell that it is very safe to micturate or not. Okay, so this is the entire story regarding the micturition reflex. Now, why is it important for us to understand this? Now, I told you 250, 400, 600, 1000. Okay, these are the important numbers. So sorry, this is 150. So these are important numbers. This is the anatomical capacity. This above this, it's impossible to hold it. Okay, sacral centers will be waiting for M region to get activated. Now, if this entire micturition reflex that we learned is from cortex, pons, sacrum, and the bladder, up till the urethral sphincter, correct? And then afferent will go here. This is the reflex in itself in a schematic representation. So below this, you have the muscles, correct? The coaptation of the pelvic floor. Now, anything above this entire part, if there is a dysfunction in this part, we call it neurogenic bladder. Okay, we call it neurogenic. We basically call it, actually, now it's being called as neurogenic LUTD, which is lower urinary tract disease or disorder. Neurogenic LUTD, because it's not just the bladder, but other parts are also involved. So neurogenic LUTD or neurogenic bladder, the part below it, if it is involved, then it's actually your other causes of other non-neurogenic problems of LUTD, which could be stress incontinence or SUI, or it could be overflow incontinence. It could be an obstruction in the lumen like kidney stones, or it could be BPH. All these causes. The pelvic floor muscles itself have become weak. So these pelvic floor muscles are there, they become weak. If they become weak, then they're going to cause prolapse. So prolapse of uterus is an important cause. So all these causes are non-neurogenic below the internal sphincter, and sometimes including the internal sphincter. If there is a combination of neurogenic and non-neurogenic causes, then it is called as mixed incontinence. So on the whole, incontinence is nothing but the involuntary leakage of urine. So if incontinence is suspected in a patient, it can be either neurogenic or non-neurogenic. Okay, this is the way to understand it. So neurogenic is involving the arc, and non-neurogenic is not involving the arc. If it involves both, it's called mixed. Now, there are different types of incontinence and different classification. The traditional teaching is to understand it as stress incontinence, urge incontinence, and overflow incontinence. Stress incontinence is when there is coughing, increased abdominal pressure, or there is sneezing, etc., or pregnancy. That is going to cause increased abdominal pressure, which gets translated into increased intravesical pressure and causes dribbling of urine. That is stress incontinence. Now, what is urge incontinence? Urge incontinence is when the bladder by itself is overactive. Okay, either the input from the cortex or the pons or the sacrum is a lot. The upper motor neuron lesions are a lot. Those the input is irritative to the bladder. So the bladder is now contracting vigorously. So if it contracts vigorously, then it's going to cause micturition and dribbling of urine. That is called as urge incontinence, where the patient is having urgency to micturate. Next one is overflow incontinence. Overflow incontinence is basically when the bladder is now flaccid, like in an LMN lesion. So the bladder now is flaccid, it expands a lot. It's not able to micturate. It's expanding, it's going above 800,000, 1.2 liters and all, but it's not able to micturate. But what happens is it's not able to micturate either because the detrusor is not contracting or the internal sphincter is not opening. So either there is a detrusor problem or a sphincter problem or both. There is an incoordination between the detrusor and the sphincter. Like the detrusor is contracting and the sphincter is contracting. So it is going to cause closure on both sides. Nothing will come out. The detrusor has to contract and the internal sphincter has to relax for the urine to pass out. If there is no synergy between the detrusor and the internal sphincter, it is called as detrusor sphincter dyssynergia or DSD, detrusor sphincter dyssynergia. So this detrusor sphincter dyssynergia is one of the important causes of double voiding. So what happens in double voiding is the detrusor contracts and then some amount of urine goes out. So patient will pass urine. But immediately this internal sphincter will contract again. So there is a mismatch now. So some amount of urine is still in the urinary bladder. So now patient feels like he has micturated and he has come. But now again, what happens is detrusor contracts again and sphincter relaxes. So again, patient goes on voiding. So this kind of irregular contraction of both detrusor and sphincter is very classic of a lesion in the infrapontine suprasacral. That is below the pons and above the sacrum, somewhere in the spinal cord. It's very classic for double voiding. Okay, so stress incontinence is either stress, urgency, or overflow. In overflow, what happens? The bladder becomes very big. The weight of the bladder actually causes the sphincters to open up and leakage of and dribbling of urine. It is the weight of the bladder or the mass of the urine that actually causes little leakage and dribbling. That is called as overflow incontinence. Overflow incontinence is a feature of LMN bladder, whereas urge incontinence is a very important cause for LMN bladder. It's not a hard and fast rule, but it's generally stated this way. So I'll come to this. Now, I told you when there is a stress incontinence, while coughing or increased abdominal pressure, this nucleus becomes important in mediating the micturition. That is called as nucleus retroambiguous. Okay, it is not just the M region or the L region. This becomes important in coughing or increased abdominal pressure, especially in stress incontinence. Okay, this nucleus becomes dysfunctional in stress incontinence. Now, what I was trying to tell you is, now let us say, if in this is the bladder, okay, this is the brainstem center, this is the spinal cord, afferent, efferent. Now, from the bladder, the sensory neurons are mostly A delta. A delta neurons are basically sensing just distension. Okay, they are not painful. They're myelinated and they're going to sense just distension. Okay, they're going to give the impulse to spinal cord and brainstem for micturition. Whereas once it goes above 600, I told you there is painful urgency, where C afferent fibers become more active. C afferent fibers are mechanosensitive. That means to say that they respond to stretch. So when the bladder stretches, the C afferent is going to be activated, and that leads to painful, pain-mediating micturition. And the same time, when there is a spinal cord damage or a spinal cord lesion, the A delta fibers are no longer getting the important nerve growth factors that for their survival. So A delta comes down and C starts increasing. C takes up the function of A delta when there is a spinal cord interruption. So once C takes up the function of A delta, even small amount of urinary volume will be sensed as pain because it is the C that is taking up the sensory information. So in spinal cord interruption, the absence of nerve growth factors will deplete the A delta. Once A delta is depleted, C will take up its function. C is inherently painful. So even with small amounts of urine, it is going to sense it as pain, and then it is going to cause irritation to the bladder. So this kind of pain at very low low volumes of bladder will lead to actually frequency and urgency. So frequency is when you're going to have increased number of urinary events. Basically, it can be dribbling, it can be proper urination, or it can be excess urination. So the number of times one actually urinates is called as frequency. They tell more than 8 times or every 2 hours if you go and micturate, then that is called as frequency. It's not a hard and fast rule. This is frequency. Second is urgency. So what is urgency? Urgency is when you are actually having a very uncontrollable urge or uncontrollable desire to micturate. Okay, so this urgency is sometimes painful also. It is not comfortable. So this urgency also happens very frequently. Okay, urgency by itself is going to be a little more frequent than usual, and it's slightly painful. Okay, it can be very painful also. That is called as urgency. When this urgency leads to incontinence itself and the urine passes out because of urgency, that is called as urge incontinence. So urgency, frequency, urge incontinence are parts of the UMN type of a bladder dysfunction, upper motor neuron type of a bladder dysfunction, where the problem is in the pons, brainstem, or the sacrum itself. Now, the severe form of all these things is called when you're actually going to urinate. You have some, if you get urgency, you're going to feel the desire, some amount of pain, and you have time to go up to the bathroom and go and micturate. You have some time. Okay, so until the incontinence happens, you have some time to wait and withstand. Okay, because the cortex is still having some kind of control, and the arc is somewhat still functional, although not properly. But in severe stages, when the interruption is very severe or chronic, what is going to happen is the cortex is no longer controlling it. It's not giving the time for the patient to wait. So as soon as there is an irritation by the C afferent fibers, the urine just goes out. So there is incontinence which is immediate, and there is no time for the patient to wait once urgency starts. So urgency without any period of gap before the incontinence happens, this is called as precipitancy. So precipitancy is basically, it's precipitating very fast. Okay, so it's a very severe form of urgency. Okay, so all these frequency, urgency, urge incontinence, and precipitancy. So all this F, U, UI, all are parts of the UMN spectrum of neurogenic bladder. So these are all problems with the sympathetic supply, and sympathetic supply is with respect to storing, SS. So all these symptoms actually are parts of storage disorder. So now there is a storage problem. The bladder is not able to store the urine. As soon as some amount of urine comes from the ureter, it is going to push it out. So this is not able to store. Now, inability to store means inability for the parasympathetic system to act. So sympathetic system is gone. So storage is not happening. So you're getting frequency, urgency, and urge incontinence. As soon as the urine comes, it is going out. So every 2 hours, the ureter is sending some amount of blood. It is sending it outside. It is not storing and expanding. So this is a problem of storage. So this is a storage problem, neurogenic type of urge incontinence. Okay. Now, let us say that you are having a problem with respect to voiding. Now, the opposite of storage is micturition, which is voiding. Now, voiding, I told you, is PP. Parasympathetic is promoting voiding. So now, if the problem is with respect to voiding, that means the flow rate is low, correct? The flow rate has come down. That means there's some kind of problem while actually passing urine. So there is a slow stream. Okay, there is not a very weak stream, interrupted stream. Okay. And most importantly, there is overflow. So I told you, when there is a parasympathetic problem, it's mostly like an element disorder wherein the bladder becomes bigger and bigger and bigger. And because it's not able to micturate, it's able to only store. So it stores itself and becomes extremely hoarded. And because the weight of the bladder, the sphincters open up and the urine passes out. That is called as overflow incontinence. It's overflow incontinence, not overactive. Okay. Overactive is urge incontinence. Overflow is LMN, or it's a parasympathetic problem. Okay, so overflow incontinence and stream problems, interrupted and poor stream, is basically a part of voiding disorder. So this is a voiding disorder. Frequency, urgency, urge incontinence is a type of storage disorder. So the entire bladder problems can be either due to storage problems or voiding problems or both. That's very important for you to understand. That's the physiology. So frequency, urgency, urge incontinence is storage, and overflow incontinence and stream problems are voiding problems. Okay, and all of these put together is called as LUTS. which is called as lower urinary tract symptoms. Now, there are certain symptoms which don't fall under each, but definitely doesn't fall under storage, which is basically dysuria and hematuria. So dysuria, hematuria is a problem which is mostly urological, which is basically because of the luminal problem or mucosal problem, which is not under voiding or storage, but it actually manifests during voiding. That's all. Okay, it's definitely not storage. It can be considered in voiding. That's all. But it itself does not represent a problem in the under the problem of incontinence. Okay, dysuria and hematuria are not problems of incontinence. If they are present, they might cause incontinence, but they are not part of the incontinence spectrum as such. So this is what I've already spoken about. Now there is a I told you if there's a problem in voiding, you're going to go talk to the patient as to what the difficulty of passing urine is. You have to differentiate between whether there's a voiding problem or there's a storing problem. So if there is a voiding problem, it is mostly parasympathetic, PP. So parasympathetic is a voiding problem. You're going to have problems in the flow, in the stream. You're going to have problems in the flow, stream, and you might have dysuria, hematuria. Okay, that is voiding problem. That's what the patient is going to come and tell you about, the voiding issue. But you as a physician should be asking about the pre-void symptoms and the post-void symptoms. Pre-voiding symptoms is whether he's able to feel the bladder filling up, which is urgency. He's able to feel the bladder filling up or not, whether he's passing a lot of urine or he's passing the urine a lot of times, which is frequency, and urge incontinence. Is he able to control the urge for a long time until he goes to the bathroom, or how severe it is if precipitancy is there or not? So all these symptoms, pre-voiding symptoms, are basically storage or sympathetic. So you're going to ask these questions. Then you're going to ask the question as to what is the problem? How is the stream? Is he able to stand up as a man? Is he able to stand up and have a strong stream to cause micturition, or does he have to sit? Does he have to squat? Because if it's a very poor stream, he won't be able to target into the washroom, but he's going to cause micturition onto the thighs. So the medial aspect of the thighs only water urine leaks out. So these kind of very sensitive symptoms don't come out from the patient at face value until and unless you ask him, separate him out from his relatives and ask him, only then you will be able to get such sensitive symptoms. So these are the problems with respect to the flow and stream. Then you have post-void symptoms, which is the next cycle, which is again storage. It goes back to storage, which is residual urine or double voiding, which is like basically the symptom of DSD. So all these symptoms come up to the next cycle storage, which is post-voiding. So here you're going to ask these questions. So this table will represent what questions to ask. So whether he's going to have a prominent pre-voiding problem or a voiding problem. If he's having a predominant voiding problem, it's a parasympathetic issue. If he's having a pre-voiding problem, it's a storage and a sympathetic issue. So based on that, we're going to divide the lesion. We're going to localize where the problem is. I told you again, if there is a frequency, urgency, and urge incontinence, it's going to be an issue with the spinal cord or the pons. So it's a or the cortex. So it is the suprapontine lesion, which is classically having frequency, urgency, and urge incontinence. The voiding will be normal completely because parasympathetic is never suprapontine. And then you're going to have no residual urine and no double voiding because all the symptoms are with respect to the frequency, urgency only, because it's the cortex. Suprapontine is basically cortex, which is basically going to tell you whether you can micturate or not. It's cortical control. Predominant major symptoms of bladder distension and won't be there. Okay, the patient is going to have inappropriate a sense of urination, especially in the medial frontal lobe. That is suprapontine. Now, infrapontine suprasacral causes are basically the spinal cord brainstem causes. So there's going to be an overlap over here, and typically DSD happens over here. Okay, I told you. And this can have double voiding, like I have explained. DSD typically presents with double voiding. Okay, here the symptoms of UMN are more than LMN. That is, symptoms of storage are more than voiding. Okay, in the infrapontine suprasacral. In the infrasacral, you can either have two problems. One, you can either have a pure LMN issue or some amount of LMN issue, UMN issue along a background of predominant LMN issue. So now infrasacral is basically the small peripheral pelvic nerves, hypogastric nerves that come out from the sacral spinal cord and affects these peripheral nerves. So here the voiding phase will be problematic. So they will have hesitancy and overflow incontinence. What is hesitancy? I'll explain to you now. Now pre-voiding is normal. That is important because there is no problem in the sympathetic supply. Sympathetic supply is with respect to the cord in the spinal cord thoracolumbar region. That because this is infrasacral, there is no problem with the sympathetic supply. Okay, that is what you need to understand. So that is infrasacral. So you have suprapontine above the Barrington M and L regions. Then you have below the pons, above the sacrum. So infrapontine, suprasacral, where you have a mixed symptoms. You will never be able to surely tell that this is a predominant UMN lesion or an LMN lesion. But mostly UMN lesions will be more than LMN lesions. And then you have an infrasacral problem. An infrasacral problem typically has no problems with respect to the sympathetic nerve system. So it has problems with respect to parasympathetic voiding problems. So it's going to have overflow incontinence and problems with respect to the motor and the sensory nerves. So here is going to delineate again whether this is infrasacral nerves that because of motor or sensory nerves. So based on this, you're going to have this particular classification. There are three important classifications: suprapontine, spinal or infrapontine suprasacral, and then sacral or infrasacral lesion. So like I told you, you please see now this urinary bladder represents, this is the detrusor, and this part, what the dots over here are going to be the internal sphincter. We're not concerned about the external sphincter here. So in a suprapontine lesion, there's no problem as such. Okay, there's a UMN lesion, so the detrusor is overactive and the sphincter is normoactive. Okay, this can happen classically, theoretically, but more often than not, a cortical bladder is seen over here. A cortical bladder is basically a bladder where there is no inhibition for the patient to micturate in. He'll be micturating everywhere and anywhere. Okay, so here the post residual volume PVR or post voidal residual volume will be there. So that actually is very less. Okay, everything goes out because the detrusor is contracting vigorously. So any amount of urine that goes into the bladder from the ureter gets exited very quickly. So the PVR is minimal. Okay. In contrast, in sacral, PVR will be very high. Why? Because it's not able to void. So in infrasacral lesions, because there's a voiding problem, parasympathetic problem, because nothing is able to go out, the bladder will become big, and the post voiding volume in the urinary bladder will be high. Okay, PVR will be high, PVR will be normal. Here, PVR actually is either normal or high. It depends. Again, it's a midway problem. So here you're going to have DSD very typically. So here you got dysenergia between the bladder and the sphincter. So you're going to have an overactive bladder that's a part of the UMN, and then you're going to have a sphincter that is very tight. That is with respect to the LMN. Okay, so you're going to have a sphincter detrusor mismatch. So both are active sometimes, both are like loose sometimes, and they can be exact opposite sometimes. So you're going to have a dysenergia over here. So you're going to have both storage and voiding problems here. Okay, then in infrasacral lesions, you're going to have predominantly voiding problems, parasympathetic issue. So you're going to have PVR that is raised, and then you're going to have a detrusor which is not contracting enough. Correct. So why it's not contracting? Because it's not receiving the impulses from the center or from the spinal cord. So because it's not receiving any input over here, it is basically disconnected completely. So it's going to be underactive. Okay, that is important for you to know. So this is the important classification. The two important classifications. This is the Lepides classifications, LAPI, Lepides classification, which classifies into 5 important types from top to bottom. Uninhibited cortical bladder, which is the medial frontal lobe. I told you what it means. Automatic bladder is basically a bladder that contracts on its own without any impulse or modulation from the cortex. This is mainly in the pons, peripontine region, and the upper brainstem. And the spinal cord. Okay, this is basically the midway lesion also. So mainly this is UMN more than LMN. Okay, that is important for you to know. Then autonomous bladder it's autonomous. It's like an autonomous university. It's going to do whatever it wants to without even asking or being accountable. So it's not under the influence of UMN. So there is no UMN modulation. It's a predominantly LMN issue. So it is either a sacral or an infrasacral type of a lesion. This is localization, Lepides classification. Then motor atonic bladder and sensory atonic bladder. These are atonic, areflexic atonic. It's very classical for LMN. So there is no tone in the bladder. The detrusor is completely flaccid. It's going to become big and big and big and big and continue to store because there is no problem with storage, no problem with the UMN. So it is going to become very big. The weight of the bladder will jump down. The pelvic floor will loosen up. The sphincter opens on its own without neural regulation, and the dribbling of urine happens. That is called as overflow incontinence. So overflow incontinence happens in motor and sensory atonic bladder, but in sensory atonic bladder, the sensory nerves are gone. So therefore, there is no pain or there is no distension, feeling of distension. So the patient will not realize that the bladder is full. So if he doesn't realize the bladder is full, how does he know? The bladder is going to become big and big and big. So he'll have to lift his shirt, see the suprapubic swelling, press on the suprapubic region, and that causes micturition. That's what he has to do. Okay. Or he has to squat so that the pressure increases intra-abdominally, and then he has to pass out the urine. In motor atonic bladder, you're going to have sensations which are normal. You're going to feel the sensations, but motor activity to initiate and push out the urine is not there. So he's going to sense the feeling of bladder being full. Once he senses the bladder is full, he's going to actually again stimulate. Okay, he's going to put a hand in the medial aspect of the thigh. He's going to cause stimulation of the medial thigh. And again, he's going to put pressure sometimes or squat. And then again, he's going to give that entire pressure to micturate. Okay, so that is motor atonic bladder. So that micturation maneuver is called as Creed's maneuver. Okay, wherein you have to squat or put pressure on the suprapubic region to micturate. Okay, in one, pain is not there, and because classically pain is not there, the patient can have be untroubled by it, leading to a lot of infections. Recurrent UTI. So the bladder becomes big, right? The bladder becomes big in infrasacral lesions, in motor and sensory atonic lesions. Because it becomes big, this mucosa goes on becoming more and more convoluted like this. It is going to cause outpouchings. And in these small outpouchings, there are going to be infection nidus. There are going to be stones. There's going to be granulations. It leads to chronic cystitis, and malignancy risk is very high. Okay, so this is all about the 5 classes of Lepides. Lepides classification of neurogenic bladder. Now, this is the second classification. This is Lepides. The second classification is the International Continence Society. So International Continence Society classifies the bladder by urodynamic studies. So urodynamic studies is the gold standard to know whether there's a sphincter problem and how much it is, whether there's a detrusor problem, how much it is, or if there's a sensory problem and how much it is. It's able to quantify it. So detrusor, sphincter. So this sphincter is basically internal sphincter only. Unless told otherwise, it's internal sphincter. Then sensory sensations. So whether it is normal, underactive, or overactive in each, you're going to grade it based on urodynamic studies. So based on that, you're going to classify. That is the International Continence Society classification. So this is the important classifications in neurogenic bladder. So we're talking still about neurogenic bladder, where the problem is urge incontinence. It comes under the banner of urge incontinence. Okay, with the other 2 types are stress and overflow incontinence. Okay. Now, basic investigations that you need to give in Harrison's, they mentioned avoiding diarrhea, very easy. Bladder stress test, make the patient stand up after he has to not pass urine. So after a few hours of waiting, the bladder gets filled up. Once the bladder gets filled up, you're basically going to visualize if there's any leakage. So you're going to ask the patient to spread his legs out and hold a small gauze pad beneath the genitalia and ask the patient to cough. Once the patient coughs, if there's a leakage of urine, then it is positive. Okay, it's positive for a stress test. It has a positive predictive value of 78 to 97%. Then you do a post-voidal residual volume. So there's a residual volume that happen we have kept a cutoff of 100. So below 100 to 50 to 100, below that, if it's there, that's normal. Okay, if it's above 200, then it is definitely abnormal. The midway range requires more repeated testing and further evaluation. So a PVR of more than 200 or 150 or 1/3 of the total volume of the total volume that has been voided, if it persists in the bladder after 10 minutes, then that is called to be significant PVR. So PVR rise is very classical of what type of problem? Infrasacral problem. Infrasacral problem. It can be present in suprasacral infrapontine also. Okay, but there is no problem and there is no PVR problem in a suprapontine or a pure UMN lesion. And a pure UMN lesion has a normal flow rate. The flow rate or the flow is normal in a pure UMN type of bladder. Okay. Urodynamics is definitely not recommended in every patient. It is recommended in only patients whom we don't have clear data as to whether it is which type of incontinence it is and what type to give. When you give, because the treatment is based on what type of incontinence, whether the detrusor is the problem or the sphincter is the problem or the sensation is the problem. Based on that, we need to give treatment. Because we are unable to do so, if we are unable to do so, we need urodynamic studies, which is the gold standard. Okay, it's invasive, and you can also do cystometry. Okay, there's a cystometry where you actually put a dye and you go into the bladder and measure using a manometer there. Video cystometry also can be used to know the each face-to-face analysis of micturition. I'll come to it later. Now, now we come to the topic proper, which is incontinence. Now, incontinence is an important topic which can be reversible or problematic. So, a reversible cause of incontinence or incontinence that is treatable easily, we should be knowing. So, Harrison puts this nice table where before going to stress incontinence, urge incontinence, you need to rule out certain important common things. For example, hyperglycemia. So, hyperglycemia is basically going to cause some amount of polyuria. It's going to cause osmotic diuresis and that can cause to frequency and urgency. That's all. Hypercalcemia, same thing. Okay. Excess caffeine, fluid intake excessively, volume overload with increased urine production at night, venous insufficiency with edema, diuretics given in the night, congestive heart failure, okay, and patients with chronic illness, okay, restraint that interferes with mobility. If mobility is completely low, the bladder also loses its entrainment, okay, depression, anxiety, and lower urinary tract infections. Very, very important. This is the most important cause for urgency. If you find a young patient, young lady with in the reproductive age group who's sexually active, please understand whether she has dysuria or not. If she has dysuria, the cause of urgency is UTI, unless proven otherwise. So basic thing they need to send is a urine routine and microscopy or a culture if it's if you're expecting that it's going to be a organism that is atypical. So, for example, it's a diabetic patient or a immunocompromised patient in which urinary tract infection becomes the most important cause of urgency. Okay, you're going to have postmenopausal lady. You're going to have now, it's not a reproductive age group. It's going to be postmenopausal lady who's going to have deficiency of estrogen that leads to senile vaginitis and what we now are calling as GSM. Okay, GSM is basically genitourinary syndrome of menopause, wherein you're going to have a lot of estrogen deficiency, which leads to atrophic vaginitis, prolapse, etc., which are all a lot of concurrent symptoms that takes place in a postmenopausal lady. And also they're going to be having incontinence because of these conditions. So you're going to give a topical estrogen cream for this patient. Here you're going to give antibiotic treatment and frequent hygiene, genital hygiene. So this is very important for you to realize the reversible cause of incontinence. Stool impaction, a rectal stool impaction is an important cause for incontinence. Okay, so this is important because it's going to cause irritation of the bladder outlet and obstruction. So these are all the cause of reversible cause of incontinence, where treatment is not a protracted course. If you have ruled all of this out and if you come to a place where it is stress incontinence, or if you find it's an overflow incontinence, the treatment diagnosis is very protracted and it's going to take a lot of time for you and the patient to adhere to the diagnosis and management. Okay, so these are the reversible causes that you need to understand. Okay, so this is an important table which tells you yet another important cause of incontinence, especially in older age group. In geriatric patients, the most important cause for incontinence, be it whatever frequency, urgency, is drugs. So the most important drugs that we all know is anticholinergics. So anticholinergics is going to cause clouding of consciousness in a patient and also going to cause incontinence. Okay, you can give it for a lot of other conditions. Okay, it can be any condition that you're giving for. It's going to precipitate glaucoma. It's a lot of issues with anticholinergic. So anticholinergic is never to be forgotten. It's an important cause for incontinence. Okay, then at the same time, you're going to realize that diuretics in any age group is going to cause incontinence. It's not causing incontinence. It's basically going to cause increased frequency, increased amount of urine to be poured. So at this point of time, I want to tell you this is very important to be ruled out in a patient of incontinence. You need to measure the 24-hour urine output in a patient whom you're going to suspect incontinence. He might go and tell, I'm going to have a lot of urination. I'm having nocturia. Nocturia can be a symptom for both BPH related obstructive event, or it could be just because of polyuria. So please rule out polyuria in any patient whom you are suspecting incontinence. Okay. Other important causes of tricyclic antidepressants, which are going to have anticholinergic effects. and then alcohol and caffeine. Okay, both of these are most important causes that can cause problems of incontinence. Okay, that you need to remove. Most older patients with this is an important point that I have picked up from Harrison's. Most older patients with symptoms of incontinence should have a post-void residual determination. So Harrison's is actually recommending a PVR estimation in old patients with incontinence, especially men, diabetics, those with neurological disorders, and those with symptoms of voiding difficulty. Now, if this statement you would have not read, if I told you there's a diabetic patient with a neurological problem, an old guy with a voiding difficulty, would you do a PVR? Most likely not. But Harrison says PVR is important because this neurological problem can be either due to a spinal cord sacral problem or peripheral nerve problems. And they both happen in a good amount of incidence. So you can't obviously assume that it is diabetic cystopathy or a peripheral nerve problems and not treat it. So it's important for you to treat both the causes. So a PVR estimation lets you differentiate between a predominant storage problem and a predominant LMN problem or a voiding problem. And the treatment becomes completely different. Okay. And it's difficult to detect by history and physical examination alone. Okay, so it's difficult to detect. So that's why you need to do a PVR estimation. And a PVR less than 100 is acceptable. Okay, more than 200 definitely needs management. That means the bladder is unable to void. That's very important to you. So incontinence, I have told you, it's the leakage of urine, which is involuntary. So you have stress, you have urge, and you have overflow. This is called as OAB or overactive. Okay, please don't get confused. Overactive is urge incontinence. Stress incontinence is the part wherein it's not the arc. I told you that the maturation reflex arc, it's below that. So it's the pelvic floor that is problematic. It's the urethral hypermobility that is problematic. It is the weakness post-surgery that has caused you to stress incontinence. So stress incontinence is a problem of the muscle or the pelvic floor. So all that you need to do in this patient is just train the muscle. If you're unable to train by exercising or Kegel's exercising, where you're going to sit and you're going to stimulate, basically you're going to contract the pelvic floor muscles to strengthen it. This you're going to do chronically. That is extremely beneficial and probably the only beneficial thing that is recommended in stress incontinence. After that, there are hardly any drugs that can help you. So if it's not working, either by training the muscles by yourself, if you can go for physical therapy. So physical therapy is when you are not training by yourself, you're going to have stimulation. So you're going to have neural stimulation of the pelvic floor muscles, which are going to strengthen it. Okay, so that can be done. If it's not done, there is no drugs in the middle, you're directly going to go for surgeries. So what surgeries you're going to have? Let us say you're going to have prolapse uterus. You're going to have urethral hypermobility. So if it's a urethral problem, then you're going to give a artificial urethra. Okay, sphincter, you're going to put an artificial sphincter. If it's a problem with the pelvic floor, you're going to do, if it's a female with prolapse, you're going to do a TVT or you're going to do a TOT, which is basically tension-free vaginal taping. So it's going to strengthen the pelvic floor basically. So that is all about stress incontinence. Stress incontinence in males are not that important or not that frequent as compared to females. Okay, whereas urge incontinence is mostly neurological. Non-neurological cause of urge incontinence could be UTI. I told you reversible causes. The mnemonic for which is diapers. Reversible cause or transient cause of urge incontinence, where you're going to have a lot of causes which will come to. So remember the word diapers, which is going to tell you the reversible cause of urge incontinence. So don't jump and say it's a neurological problem unless you've ruled out the other reversible causes. So urge incontinence, the treatment for urge incontinence is basically drugs. So these drugs are very important for us to know. It is anticholinergics that you can give, or you can go into give basically beta-3 agonist. So beta-3 was the receptor that was on the bladder wall that was actually relaxing the detrusor via the sympathetic nerves. Now, if I'm going to go give an agonist to beta-3, it is going to relax. So an overactive urgent bladder will be calmed down. So a beta-3 agonist like mirabegeron or vibegeron is going to cause relaxation of the overactive bladder or urge incontinence. Overflow bladder is the bladder has become very big. So you're going to use different maneuvers to cause urination. So the cause of overflow incontinence has to be confirmed. Okay, so it can be with bladder outlet obstruction or without bladder outlet obstruction. So this could be like BPH, prostatic cancer, prolapse, which was causing obstruction. So in these patients, you have to do a USG to go back and see the kidney if there's hydronephrosis or if there's a recurrent UTI and treat it. This requires an emergent urological intervention. If there is no bladder outlet obstruction, the cause of overflow incontinence has to be searched properly. Okay, so you need more imaging techniques. So which of the, I'll come to the classifications again, which of these is not a risk factor for incontinence in women? Okay, multiparity, obesity, family history, age, smoking, high impact exercises, and caffeine. So which of this is not a risk factor? So if you actually go on thinking it, you'll not be able to ever arrive at an answer, especially with risk factors. All except for caffeine are considered to be standard proven risk factors for incontinence in women, except for caffeine. Caffeine is not there. Although it's there in the causes of incontinence, reversible incontinence, it's not a risk factor for incontinence, which is proven by trials. So if we look at this Harrison's graph, which talks about the 3 different types of incontinence, mixed including. So as the age goes on increasing, the incidence of stress incontinence increases because of the senility and the fragility of tissues. The muscles and sarcopenia will cause the pelvic floor muscles to become weakened. Estrogen deficiency happens, and that leads to prolapse of uterus and pelvic floor weakening, causing incontinence. So that is stress incontinence, where a cough or posture change will go into, not posture change, cough basically, or increased abdominal pressure or little amount of bladder filling will cause leakage of urine. If you see, the urge incontinence is declining. Okay, that is because of increased treatment of neurological conditions. So this is mainly because the decreased incidence of urge incontinence is mainly because of beta-3 agonists and anticholinergics, the drugs. Both of these is going to cause decrease in the overactiveness of the bladder. The detrusor overactivity, or DO, is actually decreased. DU is detrusor underactivity. DO is detrusor overactivity. Okay, now female incontinence, 50% of the females have incontinent episodes after the age of 50. So this is a very important statement. 50% of the patients have incontinence. It's common in women, especially in pregnancy. Incontinence is very common in women, especially in pregnancy. However, not all women who develop urinary incontinence will have symptoms indefinitely. That means it's transient. So we should know the diaper mnemonics to rule out transient causes of urge incontinence. Okay, most important factors which led to persistence of such symptoms and no resolution is weight gain and transition to menopause. Always rule out polyuria in a patient whom you're treating or evaluating for incontinence. Okay, and 21% of the patients who are always end up who are healthy and no issues otherwise are going to have an involuntary detrusor contraction. So overactive bladder, in that not overactivity, but some amount of activity which is involuntary, some amount of activity which is not required is actually present in patients of 21%. 21% of healthy individuals have involuntary detrusor contractions. So this is the mnemonic that I was talking about, which is a transient cause of urge incontinence: delirium on confusional states, infection, atrophic vaginitis, which is basically estrogen deficiency, pharmaceuticals, drugs like, for example, diuretics, and then psychological or psychiatric problems, restricted mobility, which cannot be guessed, and then stool impaction. These are transient causes. So DIAPPRS, diapers. Okay. Then this is the cause that we are talking about, which are not transient, correct? So stress incontinence is basically it precipitated by stress maneuvers, more common in multiparous women, where the sphincter is not closed. Urethral hypermobility or pelvic floor dysfunction leads to stress incontinence. Physical therapy is the mainstay. The mainstay is Kegels exercises or physical therapy. We're going to strengthen the pelvic floor muscles. Overflow incontinence is where the bladder is completely distended or very big. Voiding is not happening. This is either because of bladder outlet obstruction, which is very important for you to realize, although it's less common, because it requires decompression. You need to divert or you need to remove the obstruction, like BPH, stones, etc. Or you can have impaired contraction of the detrusor, or DU, detrusor underactivity. The terms DO and DU are all basically terms that are determined by urodynamic studies. Okay, so impaired detrusor contraction can be due to cauda equina syndrome, anticholinergic medications, or autonomic neuropathy, and as common as diabetic cystopathy. Diabetic cystopathy is one of the important causes for large big bladders, which are not active, where the detrusor is underactive. Okay. Then urge incontinence, which is the most important type that we need to know, under which we have neurogenic or non-neurogenic. Neurogenic causes are within the micturition reflex from the cortex up till the bladder walls. So where you're going to have detrusor overactivity or DO. So here you're going to have urgency. So it is FU and UI, frequency, urgency, and urge incontinence, where it's going to be precipitated by running water, cold temperature, and all that, and moderate to large leakage of urine. Incontinence classically is going to have large leakage of urine, whereas in stress incontinence is dribbling. It's small drops of urine that's going to come just because of the increased pressure of the transient increased pressure of the abdomen. So the three important types, stress urinary incontinence, we have finished. More common in young women. Okay. So, but the thing is, if it's happening in old women or in patients with postmenopausal status, then the prognosis is poor. Prognosis is poor because they are having poor coaptation of urethral and pelvic muscles. Okay, because of which, and this poor coaptation is mostly could be due to urethral hypermobility, where you do a sling surgery or you do a artificial sphincter is inserted, or an intrinsic sphincter pathology. Okay, so this pelvic floor disruption, this can happen post surgery. So that's very important for you to know. If there is a prostatic tumor which is going to impinge, it is going to cause bladder outlet obstruction, and hence it's going to cause overflow incontinence. So very important for you to people who are listening to this to understand. If there is a tumor or a intraluminal obstruction, at that point of time, it is going to cause blockage and overflow incontinence, because the bladder is going to get completely filled up without excreting the urine. But post-surgery, if there's a problem, if the nerves are going to get dysfunctional, if the muscles are not sutured properly, the muscles becomes weak, and that leads to stress incontinence. So from overflow incontinence, the patient became stress incontinent. So that's important to understand. So due to TURP surgery or prostatic surgery. So here the treatment is very important, which is only physical therapy mainly. So bladder training, pelvic floor muscle exercises, topical vaginal estrogen for genitourinary syndrome in menopause, and pessaries. In men, there is a good study that tells that duloxetine plus this behavioral therapy is superior to just behavioral therapy. So duloxetine is FDA approved with behavioral therapy for treatment of stress incontinence in males. And this is more important in patients who are not having post-surgical complications. Post-prostatectomy, you can't give duloxetine and think it might work. It might not work. So transurethral bulking agents, perineal slings, and artificial urinary sphincter. So if it's a predominant sphincter problem, you're going to give an artificial sphincter. If it's a pelvic floor issue, you're going to do a TVT or a TOT based on the patient preference. Next is 3IQ, is urge incontinence. Urge incontinence is not overflow, it is overactive. Okay. Detrusor overactivity is there. Here you're going to have a typical UMN problem where the detrusor is constantly acting. Now, there are certain patients who are, this is mostly neurological. There are certain patients in which the detrusor is not contracting vigorously, like urge incontinence, but it's just quivering. So this quivering is not actually causing contraction. So it's just moving like this and hyperactive. That is basically called as hypercontractile. Okay. So it's like atrial fibrillation. Okay, basically it's not causing contraction, but it's completely stimulated all the time. So here the treatment will be bladder training, pelvic floor muscle exercises, removal of drugs, diet, remove the caffeine. Okay, this is very important for you to know. So anticholinergics are also given. Here you're going to give beta-3 agonists, which are more superior, and anticholinergic usually because patients will be having old age, they might have cognitive decline, dry eyes or dry mouth. All these autonomic symptoms, side effects are more. So instead of anticholinergics, you can give beta-3 agonists, which is mirabegron and vibegron. Vibegron has higher efficacy, but mirabegron is more studied and more available, and cost is lesser. So here, vibegron and mirabegron are beta-3 agonists. Beta-3 agonists. The other class which causes side effects, but extremely efficacious also, are anticholinergics. Here, trospium and sulfenacin, please remember. The trospium and darifenacin don't cross the blood-brain barrier. So they might not have that cognitive fogging. So trospium is very important, very much used, very much better drug in the anticholinergic category, and tolterodine. So tolterodine, sulfenacin are all anticholinergics that you can use. Okay. So a combination therapy is the next. If it doesn't work out, you're going to do a combination of sulfenacin plus mirabegron, or you're going to give a transtibial nerve stimulation. Transtibial nerve stimulation, please remember it is tibial nerve. Okay. So you might ask how it might work. Tibial nerve is a somatic nerve. So the ankle in the medial and lateral malleoli is basically stimulated. That stimulated nerve has a retrograde conduction up till the plexus, sacral plexus. At the sacral plexus, the inhibitory interneurons are going to get modulated. So the overactiveness of the sacral plexus is reduced so that the parasympathetic activity is reduced. So that's the reason why we give transtibial stimulation. Sacral neuromodulation, directly go and stimulate and modulate the sacral plexus or the peripheral nerves coming from the sacrum. You can give intravesical botulinum toxin. It's now being called as ONA botulinum toxin A. ONA botulinum toxin A is going to be injected intravesically. You're going to give about 15 to 20 spots on the urinary bladder. You're going to be stimulating. That causes reduction in the activity of the overactiveness of the bladder. You can do augmentation cystoplasty, where you reduce the nerve plexi in the bladder wall and put a patch which is inactive. Okay. If there is a complete spinal cord transection, if the spinal cord is transected, the peripheral nerves are still okay. So you're going to go to the proximal end of the peripheral nerves and stimulate it. So if there's a spinal cord transection completely, the peripheral nerves in the bladder is there. So you're going to go and stimulate the peripheral nerves and cause the bladder to be less active. Okay, that is basically when complete spinal cord transection is there. If there is an incomplete spinal cord transection, you're not going to stimulate it, but you're going to modulate it. So that is called as anterior root modulation. Okay, where the anterior roots are still being modulated based on the spinal cord impulses, which are present but not completely transected. Next is overflow incontinence. This is because of detrusor underactivity more than bladder outlet obstruction. Detrusor underactivity is a large filled bladder. So there's going to be an LMN neurogenic bladder. And the other important causes are Fowler syndrome and bladder outlet obstruction. So LMN neurogenic bladder is a neurogenic cause. For example, diabetic cystopathy, peripheral nerve problems. And then you get a non-neurogenic problems like intraluminal obstructions like BPH. And then you get a functional disorder like Fowler. Fowler syndrome is when the bladder sphincter becomes completely constricted. It won't relax. So because the internal sphincter doesn't relax, the bladder becomes completely big and swollen up. Okay, that leads to overflow incontinence. This happens in young females. And the only treatment that is important for Fowler is sacral neuromodulation. Okay, sacral neuromodulation is the most preferred method of treatment in Fowler syndrome. So I told you there's a type of contraction where the detrusor is like atrial fibrillation, where it's quivering, but it's not contracting. So this is called as detrusor hyperactivity and impaired contractility. Contractility is impaired, but it is hyperactive. This is like atrial fibrillation. This is called as DHIC. DHIC. Okay. DHIC is important to know. Okay. So treatment for overflow incontinence is intermittent catheterization. You can't go for Kegels exercises. You can't go for pelvic floor training and all that. So those don't become the answer. The answer is intermittent catheterization and self-catheterization. Okay. So you can do Creed's maneuver, with patient himself can do it. If there is a bladder outlet obstruction, you're going to give treatment by doing TURP. Their TURP caused stress incontinence. Here the treatment is probably TURP. You're going to give alpha blockers or alpha blockers plus alpha reductase inhibitors. You're going to give alpha blockers only when the PSA levels are not very high and the flow rates are very good. If it becomes more severe, where PSA is very high, flow rates are very bad, where the stream is also very bad, you're going to add 5-alpha reductase. So basically tamsulosin plus you're going to add finasteride or dutasteride. So without bladder outlet obstruction, the treatment becomes difficult because it's mostly neurogenic causes. If there is bladder outlet obstruction, you're just going to go and remove the obstruction and come back and look for any complications in the upper urinary tract. Okay, so this is about stress incontinence, urge incontinence, which is also called as overactive, and this is overflow incontinence. Mixed incontinence is basically a combination, and the one that started the most recent one. In the mixed, whichever started the most recent one will be treated. Okay, that is very important for you to know. Okay, treat it first. Okay, so there's a terminology called as intractable incontinence, where you do urinary diversion with stoma. You can't go for anything else. All the treatment modalities have been exhausted, and then you go for a urinary diversion with stoma. This is a important questionnaire, which I told you was 3 IQ questionnaire. It's also from Harrison's. This questionnaire lets you differentiate between whether it is stress incontinence, urge incontinence, or overflow incontinence. Okay, so this is all about incontinence and neurogenic bladder. So the summary of it is, you have to understand that incontinence is basically a large banner under which you can have stress, urge, and overflow incontinence. Under urge incontinence, you can possibly have neurogenic bladder, which is mostly UMN. Under overflow incontinence, you could have neurogenic component, which is LMN. So the micturition reflex is important for you to understand. And from the micturition reflex, you can go ahead and understand different types of neurogenic bladder, including the Lepides classification and the differentiation between UMN and LMN bladder. Okay, all of this actually helps you understand the treatment strategies and helps treat patients of incontinence better. Okay, so thank you. If there are any other doubts, I'll take them now, or you can post it on YouTube. Okay, so Barrington's nucleus or Barrington's regions is basically in the pons. It's in the medial pons. It's also called as the M region. Okay, that's where the Barrington's region is. Okay, then. Thank you.